Hi, everyone, and welcome back to the 11th annual #See Arthritis event. We are so happy to be here. I'm with Arthritis Consumer Experts. My name is Cheryl Koehn, and this is hosted by us on the Arthritis Broadcast Network. We're absolutely thrilled to be in the studio again with Dr. Marie Westby. Marie, welcome to the studio.
Thank you, Cheryl. It's always a pleasure to talk to you and your group.
It's so fun. I'm going to tell the audience a little bit about you, Dr. Westby, before we begin our conversation. So Dr. Marie Westby is a clinician-scientist at the Center for Aging Smart, a physical therapy clinical resource educator at the Mary Pack Arthritis Program, and a clinical associate professor in the Department of Physical Therapy at the University of British Columbia. She is also a Michael Smith Health Research BC Health Professional Investigator, specifically evaluating the implementation and effectiveness of TJA, which is total joint arthroplasty, rehabilitate or replacement, if you will, rehabilitation quality indicators through patient and clinician targeted toolkits. So wowie kazowie, that's a mouthful, Dr. Westby. We're always so thrilled to sit with you because the research work that you've done, and you've spent, I think, the better part of your career on this, which tells our audience something about how long it takes to find answers. The reason it takes so long is because you have to do small, medium, and large studies in the people you're interested in and the problem they face. And that has to be standardized. The methodology has to be rock solid in order for you then to turn around in your clinical life and say to a person, here's what the research proved. And I think the public doesn't understand how long that takes. So first, kudos to you for sticking with this body of research. It is so important. As someone who received a joint replacement about 5 years ago now, I have a much keener appreciation for the work that you're doing. You presented a poster, which this gets us, that's my segue into our talk today. You presented a poster at this year's meeting in Calgary, and the title of the poster, so it's an abstract, so you've yet to publish it, but it's published in the program journal, Assessing Quality of Post-TJR, so total joint replacement, rehabilitation care gaps, and patient perspectives. So tell us first a little bit about yourself, and then we want to dive into your poster. So just to flesh out maybe what I shared with our audience in the intro.
Thanks, Cheryl. It's a pretty comprehensive intro. So I have worked in the field of arthritis clinically my entire career in the same building, which is, I know, rare these days. And I am passionate about working with people of all ages with arthritis. And I guess more recently, in the last 10 to 15 years, that interest has really grown into osteoarthritis and those that are needing to have total hip or total knee replacement, or THR, as a result of treatment failing them, in terms of interventions such as exercise, pain medications, altering their lifestyle. For those who would benefit from it, maybe losing weight to take some of the stress or load off the joint, but none of those things have worked. And their quality of life, their pain level, their ability to do meaningful day-to-day activities is so compromised that it's time for them to look at the next and sort of final phase of care, which is a total joint replacement. So when I was working clinically with large groups of these people, we really noticed there was tremendous variation as to what people receive for information before their surgery, how long they were in the hospital for, and what kind of care they received after. And we were very lucky at the Mary Pack Arthritis Program, as a publicly funded program, to be able to offer a comprehensive group and pool-based program to meet their needs and discharge them when we felt they were ready, when they achieved some functional milestones or met their goals. But other models of care started to pop up in our province and other provinces, where they started to put caps on the number of visits that were covered through public health, or other places where just depending on who your surgeon was, which hospitals or health authority you're in, you would have a very different care pathway and more or less rehabilitation offered to you. And so I started getting really curious and concerned about that care variation and the overall quality of care that people are receiving. So that's what's led to my work today.
Yeah,
No,
I
go
was
ahead.
just going to say it's interesting. As a patient myself, I have RA, I've had a total knee replacement. When you sit in the patient side, in the patient waiting area, people talk to each other.
Mhm.
Interestingly enough, they're curious to know what the other person's experience is. And personally, Marie, I was shocked. And it's why one of the reasons I'm a patient partner in your research,
Mhm.
because I have heard firsthand how little service someone received after total joint replacement versus someone who had actually a lot of service. And the separator between them might have been a few city blocks if you happen to be in different care jurisdictions. And I find that frankly unconscionable.
It's
Yeah.
alarming, and
Yeah.
it's inappropriate, and it's inequitable. And so I was aware of it locally, but I wanted to explore how big of an issue this was across the country. So we had done something similar, excuse me, in terms of surveying clinicians, mostly physiotherapists, about 5 years ago, and asked them about the quality and consistency of care they gave us. And it was surprisingly low. Often we will over-report when we're talking about the services we provide, but it was lower than 30%. We're meeting what we call quality indicators or standards of care that our team developed for rehabilitation. So we repeated and changed the wording and did some usability testing with your help and our other patient partners to make sure the questionnaire, when converted to a patient-facing survey, was understandable by patients here in BC as well as in Quebec. And then we launched that across Canada because now we wanted to hear the patient's perspective. So we asked them about the quality of care they received, what aspects of rehabilitation were important to them, regardless if they had received it. Would that have been important to you? We asked them very specifics around their care experience in terms of being heard, having information explained to them in a way that could be easily understood, as well as their satisfaction with their overall pain, their function, and their overall satisfaction as a result of the surgery. And we also dug in a lot. So this is a detailed survey, asked them to recall a lot of information. So we were targeting people that had just completed their rehab or had had their surgery within the last 4 months. So a very narrow window so they could recall these details. And we asked them about how many visits you had, how soon after you were discharged from hospital did you start your surgery? How was your rehab paid for? Was it publicly funded? Did you pay privately? Did you use extended medical? So we're really interested in all the models of care the different provinces provided.
When you look at some of those findings from the poster that you presented, what were the big shockers for you? As someone who's been working in this field for a long, or were there any?
Well, I guess it wasn't a shocker, but it just confirmed is a big shocker how varied care was across the provinces.
Okay.
It was all over the place in terms of how they approach care and models of care. It was somewhat consistent from province to province as to how many of these quality metrics or indicators people met. And on average, they met 48% or just under 5 out of 10 of these quality indicators were met. Varied a little bit by province, but it wasn't statistically significant.
Right.
The one concern I had when we looked at different sort of clinical features, as well as health sort of personal demographic features, is the only, it's always a mouthful, statistically significant difference in the quality of care received was noticed by age. Okay. And the older the age group, so we used age groups like 45 to 54, 55 to 64, because that's what the Canadian Joint Replacement Registry uses to capture ages. And for every older age bracket a person moved into, their quality of care went down. What they reported is their quality of care went down. And that was concerning because the older the patient, the more likely they're going to have other health issues or comorbidities or other functional challenges that probably warrants more rehab care, not less.
Yeah, I mean, you would wish that would be the opposite, right? Yeah. Because as you age, you become more frail, more vulnerable in your own environment, in the world environment around you. That is concerning. When you tell the audience, Dr. Westby, you use the term quality indicators. So in my simple non-researcher head, I say, okay, that's a checklist for me, let's say as a patient,
Mhm.
that I can actually sort of make certain I'm getting the things I'm supposed to get that are proved to result in a good outcome. Is that accurate? Is that a sort of
That's a
simple way of putting it?
It is a simple way. So a quality indicator is basically a statement or a standard. The definition is a minimum or minimal, sorry, let me get it, minimum standard of care a patient should expect to receive, in this case, after a hip or knee replacement.
Okay, so
So
give us one of those. Give us one, yeah.
I'll give you an example. A lot of our indicators reflect assessment because it's important before we, as physiotherapists, start to give you care, we assess to see where your needs are or where your gaps are in day-to-day function. So quality indicator number one is about assessing post-operative pain, which we know is significant, especially after a knee replacement. So the statement is, did you have your post-operative pain in your operated knee assessed at least twice at baseline when you first started care and before you were discharged using some sort of standardized metric or measure, such as a numeric pain rating scale, 0 to 10,
Right.
a visual analog scale, mark along the line, or sometimes there's even little questionnaires that ask you about all different aspects of your pain, and there's 5 different questions. But it's standardized. So I, as a therapist, can see how you did at the beginning, pick up where your challenges were with pain. Maybe it's with sleep, not with walking, but it's pain at night with sleeping. And then re-measure you at the end of the rehabilitation, one, to see if you're better or you need some more guidance on managing your pain, but also to see if my treatment was effective.
Right.
Was what I offering you and what you were able to carry through on with at home effective for managing your pain? And if not, if I measured earlier in the course, I could sort of redirect care or build on additional strategies.
Right.
So that's yes, and that's a check mark, yes or no. I received that, and we have created a checklist format for patients, as well as a booklet where they can follow through and understand why this is important and how to check it off, how to write down their scores if they're having some other tests done, and how to have that conversation with their therapist. We really want them not to be intimidated to ask the therapist, should you be measuring my balance? We know that up to 50% of people after a hip or knee replacement fall in the first year after their surgery. Balance should be checked. But how does a patient feel comfortable thinking, I don't think she's checked my balance? How do I ask her to do that?
Yeah.
So it's some tools and resources to give them some confidence and knowledge on what to ask.
Do you feel your community of physiotherapists who are delivering these services, are they open to improvement? I mean, I could see this being professionally a little bit intimidating.
It's been interesting because the research that we're now just wrapping up was very much that, how receptive are physiotherapists to changing care. We're asking them to change, how they care. And I think the biggest barrier, which we see in the literature as well, is time.
Right.
How do I fit this in? I'm already so busy. I'm already doing all these things. And so we have been trying to develop tools that will save them time, nice reminders, infographics, just to cue them in. Don't forget to ask about this, and trying to show them that how much time you will save with more effective and efficient treatment had you assessed this right at the start, or had you included this, and maybe the client won't have to come back for additional treatments in the future. And you can free up spots for other patients. So I say time and the additional burden they think it's going to add to their care or caseload. And that's a hard one. That's not unique to our project in terms of what therapists tell us. So we're looking for clinical champions, those change agents, those people that are really interested in having that social influence in their practices to help demonstrate and model that this is effective and we can deliver better care by following some of these indicators.
And we're going to help you find those champions, because at the end of this talk, we're going to show some contact information and where people can go and learn more about all of this great research that you've been doing on quality indicators, on the care being given to people with joint complaints, joint replacements. Super, super important. coming out of the meeting, this is sort of to try to wrap us up a little bit, Dr. Westby. We know you've got lots to do in your day. The meeting's theme this year was Ascending to New Heights, Peaks of Innovation in Rheumatology. And I know you and I had a chance to see one another at the meeting, and you made a comment about AI as it relates to the field in which you're an expert. Just share with us maybe some of your views on where you're at right now with the use of AI, what you think the implications are going to be to you, to your profession, but also to patients.
Well, I guess I'm at the early awareness phase that it's coming. It's here, and we need to at least accept and be aware of it. And I'm aware of colleagues who are looking at using AI just in physical therapy practice, like AI scribe to take their notes and their history. Artificial intelligence is going to fit into a lot of the remote monitoring and administration and messaging of clients. So there are a number of organizations that have developed sort of remote monitoring and apps for people after hip or knee replacement. And it will sort of monitor someone's range of motion or pain or physical activity levels and send alerts when it notices that those have gone down or it's problematic. And it will generate AI generated messaging to prompt them to either contact their surgeon or their rehabilitation professional, or to increase your exercise, or to remind them what the strategies are for pain relief. So those are just some that I'm aware of that are already happening. But I'm nervous and excited about AI, but I think it has tremendous potential in lots of areas of healthcare. But I'm going to sort of sit back a bit. It's not an area that we're going to pursue in particular for my work, but I can see a lot of it lending itself nicely to integrate that.
Yeah, I think some of the things that we heard at the meeting also was how one safeguards against inequity in AI. I mean, AI is only as good as those people building the algorithms, and typically they are socioeconomically advantaged. They may not be considering the things that are in underserved, that challenges that underserved populations face. So I think that's certainly one of the key areas that ACE is keeping a close eye on, because like you, we're really working on equity, diversity, inclusion. Those aren't bad words in our world. Those are good words in our world. And so I guess with that, Dr. Westby, any other things you want to add here at the end as we close our conversation?
No, it's just I always enjoy talking and watching all your Arthritis Broadcast Network sessions, especially when I haven't been able to attend a particular session. I know it's going to be really nicely highlighted and engaging to go back and follow. So I really appreciate your group always taking the time to do these.
Thank you. It's powered by people who care, you and your colleagues across rheumatology and the basic science field, and always being there when we send out a note saying, hey, come into the studio. We are just really blessed to have just fantastic caregivers in our world of rheumatology. So thank you so much. Again, thanks to the CRA and the HPA for participating so wildly in the #CArthritis event. Thank you, Dr. Westby. We'll let you go. And thank you to the audience. Tune in to our next episode coming along shortly.
Great. Thanks so much.
Thanks. Bye-bye.